So what are the common complications, or what does a diverticulum actually do? One, it can either be asymptomatic, which means you're finding out the patient has a diverticular only while doing a CT scan or while doing a colonoscopy, which was meant for a different cause. For example, if you just want the patient had a lower GI bleed, or you just want to screen the patient for colorectal cancer because the age is high, the patient has anemia, something like that. There you incidentally diagnose a diverticulum, or you discover a diverticulum. That is called an asymptomatic, which means the patient doesn't have any symptom pertaining to the diverticulum. He was screened incidentally for a different cause. Now, if the patient is symptomatic, that is one thing. There is something called symptomatic uncomplicated diverticular disease. Just like the name suggests, it is symptomatic, which means commonest symptom of diverticulum is abdominal pain. Okay, then we have crampy abdominal pain. In fact, this entity, SUDD, is called as SUDD, or symptomatic uncomplicated diverticular disease, is almost similar to IBS, irritable bowel syndrome. The pathogenesis, the pathophysiology as well. So pathophysiology in IBS, visceral hypersensitivity, altered gut motility, central neural dysregulation, all of this has also been studied to be similar in patients with SUDD. Okay. So here again, they'll have abdominal pain or abdominal cramps, typically like what you have in IBS, which will often be relieved either by passage of flatus or by passage of stools. So that is the typical history of IBS. IBS, you have their own criteria: abdominal pain, which is altered, which is associated with altered form or consistency of stool, or even improved defecation. Similarly, out here also abdominal pain, which is relieved after passing stools or flatus. Okay, that will be the particular thing. And commonly, it's in the left lower quadrant, like you say the sigmoid. That is where the common location is for the pain. The patient might sometimes have tenderness. If you palpate the abdomen, there will be tenderness sometimes, but there is no rebound tenderness, or there is no rigidity or guarding. No rebound tenderness, there's no board-like rigidity, guarding and all. That mostly it points towards more of a peritoneal cause. So that is not there for this patient. Again, what will you find in the patient? The patient might be having some low-grade inflammation, intestinal dysbiosis. Okay, that is the commonest thing, like you have in IBS patients. So treatment also would be giving some probiotics, like something which targets your lactobacillus bifidobacterium, or even you can give BSL-3 that has been shown in certain trials to help in assisting patients with irritable bowel. Second one is rifaximin. So treatment of SUDD is similar to treatment for IBS. You give antispasmodics, like you can give this thing, mebiverin, or mebiverin is a commonly used, or rotaverin. Okay, and along with probiotics and rifaximin. That is about SUDD. Now, diverticulitis. Itis means there is inflammation of the diverticulum as such. And here in SUDD, there is no inflammation. Okay? So how do you make this out? Inflammation is present. It's mainly by the patient's clinical picture, which is also supported by radiology. So you take an X-ray. If at all there is any air, which you can see over there, then it's definitely a complicated disease. Or if you can take a CT scan and find out if there is a thickening of the diverticular wall, there's intramural thickening. Okay, or if you have the presence of certain features like edema, if all of this is present, or even the extravasation of contrast. Okay, there's an extravasation of contrast, which means the patient has gone in for a diverticular complication. So any of that is present, it could be a diverticulitis. Clinically, what will the patient be having? Severe tenderness will be there. If the patient has any features of perforation, obstruction and all, there will be tenderness, rebound tenderness, as well as rigidity might be present. Okay. Similarly, in a patient with a diverticular hemorrhage, what will be the commonest thing? Bleeding. Diverticular bleed is usually painless bleed, and it is an intermittent bleed. This is something which we have to know. Painless, it may be an intermittent bleed. It's usually self-resolving. Even if you don't do anything, it will automatically stop by its own. It will be a painless bleed, intermittently it will come. You'll never have a patient who's having a diverticular bleed coming with anemia for evaluation or FOBT positive. FOBT means stool occult blood positive. No, it won't be an occult blood which is positive. It will be a frank bleed. So a very common cause for patients above 60 who come with a painless lower GI bleed is diverticular disease. Okay, so diverticular hemorrhage. This is SCAD, that is segmental colitis associated with diverticular disease. Okay, so this almost is similar to IBD, like you have in Crohn's disease. There you will have a segmental colitis, which means Diverticulum is present and there is an inflammation of the mucosa as well, which is associated with the diverticulum. So you have a diverticulum, this is a small diverticulum. This is a colonic mucosa. Here you will have erythema. Sometimes erosions may be present associated with diverticulum. So this is what is called as a SCAD, segmental colitis. Only this segment is associated with erosions and erythema. So this is something similar to an IBD. If you take a biopsy of a patient from these erosions, what will you find? You can find even granularity, you'll find edema, there will be hemorrhage, there can be cryptitis, which is typically seen in patients with IBD, even granulomas. So you might even think the patient is having an IBD itself, but the presence of diverticular disease always strike you that it could be something called SCAD. So your SUDD is similar to an IBS, whereas your SCAD is similar to an IBD. In between, you have diverticulitis and diverticular hemorrhage. So these are the different manifestations of any patient who has diverticulosis. So diverticulitis uncomplicated means what? That means there are no complications. The complications, what we expect, are either an abscess or a fistula, obstruction, or a perforation. Either a diverticular abscess can develop. Sometimes what happens if the diverticular abscess is so severe, it can sometimes fistulize to the adjacent organ. Okay, it may not be contained in a particular place. Usually you have the colonic walls. This is a colonic wall and the pericholic tissue, which usually contains the abscess. Fine. It may be an early abscess, initially called a phlegmon, and then later on becomes an abscess. Sometimes the abscess may migrate to another place. It could be a pelvic abscess, or it could be a retroperitoneal abscess also. That is a stage 2. Okay. Then stage 3 is, you have different stages, the Hinchey classification. We are coming to that. In stage 3, you have the diverticulum which is already perforated. It's gone, but the neck has been obliterated again. The neck is totally obliterated, so there is no connection with the lumen. Okay, so it's a perforated diverticulitis, which means there is an inflammation out here, but the neck has been obliterated, and hence there is no connection with the lumen. So there is no continuous seepage of fecal matter. So in CT, you will not see a continuous extravasation of contrast because the neck has been obliterated. But in stage 4, what happens? It's a total fecal peritonitis, which means there is a communication with the colonic mucosa itself. So in 1, you just have an early abscess, which is usually contained well. It's a pericolic abscess because of the pericolic tissue and the mesentery it is contained. In 2, you have it's retroperitoneal or it could be a pelvic. There is some migration. It is a distant abscess. It's not just around the diverticulum. It's a distant abscess. In type 3, you have a perforated diverticulitis, but the neck has been obliterated and hence there is no communication with the lumen. In type 4, there is a communication with the lumen. So this is why it's important to know this Hinchey 4 classification is because the management options are also different for all the 4.